All right, case presentation. Again, this could be using our amazingly well written out form if you want. Otherwise, even just letting us know you have a case and we can kind of talk through it. With all of us on here, we'd love to hear kind of the cases y'all are starting to see. We do have a case of mine that I embedded throughout the talk today, so that's going to throw Kurt off, so that'll be pretty fun. And it's just super pertinent with what today is. So, but please, cases are always appreciated.
We got some stuff coming up too. Next time will be OUD and pregnancy, which is a great talk that we've given many times, and lots of other stuff coming up, neonatal, perioperative, and so on.
All right, and then tomorrow on the Wednesday Echo, understanding East African clients, Yusuf Shafi, who is from the Alliance Wellness Center. And I think this is pertinent, really pertinent. I mean, I have 2 new patients from Somalia that I just started. And then the following Wednesday, Dr. John Cole, who we all learned to know and love when we were doing the COVID Echo series. So talking about the opioid epidemic from the ER physician perspective and toxicology perspective. And
the talk following that will actually be a talk that I'm going to give on some of the other off-label medications used for alcohol use disorder to kind of extend on the talk that we had last week. So it's going to be the anticonvulsants, antipsychotics used for alcohol use disorder. So it's super fun.
All right, so the addiction connection today went up, varenicline, look, I can
Chantix.
still say it, Chantix for the treatment of cocaine use disorder. Yeah, what a interesting diagnosis and treatment strategy. So it was a pretty fun one.
Fun.
And technical assistance, we are always here if you have any questions, need help troubleshooting. You don't have to wait for one of these echoes. We will answer your calls and or emails. So that is how you reach us. And then Erin, if there's any other type of nursing support or workflow things you have questions about.
Perfect.
It's not letting me switch slides.
Apparently we're froze.
Okay, so stay tuned. I put this slide in there. Sorry, Mark. In a week or so, there will be an online resource center called CORE. You can register for echoes, find all the echoes, podcast links. The manual will gradually be releasing the manual. We will have
was Brandy?
all the
Sleeping,
forms.
didn't respond at all.
There we go. All the downloadable forms that you might need for your clinic. Different resources, where can you find naloxone, fentanyl, test strips, and all the above. Connect with other care teams as well as us, and this has a lot to do with the Wednesday Echo.
So just a treasure trove of information.
Mm-hmm. Why is this doing this?
We're having a little trouble. So today we're going to talk a little bit about some of the basic pharmacology of the stimulants, including meth and cocaine, some of the symptoms of intoxication, and just, treatments that are, most of the treatments for these things are, again, off-label. They're very interesting. And we'll talk a little bit about a methamphetamine-induced psychosis, which is interesting because just today I had somebody who had bipolar disorder on their chart when clearly it was heroin and methamphetamine. So we'll talk a little bit about psychosis and what to do and not to do. So who's starting?
You are.
I guess I'm starting
first.
So let's talk a little bit about how we categorize some of these things first. And just remember that, we look at the stimulants, as being kind of that norepinephrine and dopamine kind of things that kind of change that whole neurobiology. And that would really include cocaine, methamphetamine, or just straight amphetamines, the Adderall, things like that. Some of the synthetic canthinones, things like bath salts, would also fit in the stimulant category. Then we have another category that is super interesting, which is the empathogens, the MDMA and similar things that affect our serotonin, our norepinephrine, and dopamine as well. Typically not something that patients have addiction with, but are typically kind of weekend type drugs. And then the fun stuff, the hallucinogens, which again, kind of that same area that's affected, including 5-HT, norepinephrine, so the serotonin and the dopamine things. And that would include things like LSD and psilocybin, which is of course often in the mushrooms, the DMT and mescaline, which I have to say I've not seen a patient in the addiction clinic using mescaline. we have to think of these things as kind of a spectrum. So when you kind of think about the stimulants and this monoamine spectrum, it's on one end we have the stimulants, which again are dopaminergic typically. On the other end we have the hallucinogens, which are more serotonergic, so affecting the serotonin receptors mostly. And then right in the middle we got the empathogens, and so those give that more balanced effect. And again, not typically something that patients have addiction with for the most part. And there's, I think, a lot of debate as whether or not they're really harmful. So
If you ask, I got it.
Okay, you got it.
Sasha Shulgin, they're definitely not harmful.
They're definitely not. So now let's talk a little bit about the hallucinogens for just a moment, because there's basically two chemical types. There's the indoles, and then there's the phenylethylamines. So you've got,
Wow.
you like that? I pulled that one off. And so the indoles would be things like LSD, the psilocybins, and these things, again, look very similar to serotonin. And so you can imagine what it looks like if somebody takes too much of their serotonin uptake inhibitors, or they're using those things. You can sometimes get some pretty unusual side effects. But LSD and psilocybin kind of are very similar to the serotonin, so they can give you those kinds of things. And when you look at the phenylethylamines, mescaline and MDMA, again, that would be in that different group. Most of these things are ingested orally. And so when you look at hallucinogens, these are typically not injectable or smoked like many of the substances that we see. And again, the hallucinogens give a different effect than some of the stimulants that we see, more of a euphoria, kind of that spiritual insight, but often can also be linked to things such as depression or anxiety. And sometimes people have a quote, bad trip, right? And they get delusions or terror. And so it can go a couple different directions. And I think that's something to always understand. If you see somebody that looks like they're very delusional, they're hallucinating, and they're having terrors. So these are metabolized in the liver. And so it's important that, especially with patients with liver disease, we understand that we're going to have more trouble. But again, they're mostly an agonist, or at least a partial agonist activity, kind of activity in the brain, especially at the serotonin receptors. So they're kind of a different ball of wax. Now, cocaine, as one of the stimulants, is an alkaloid. So it's a little bit different. It's a structure that's actually amazingly very similar to scopolamine, which of course you buy in the patches. These, of course, come from the coca bush. And coca bush, and they are used a couple different ways. Sometimes they're a base that's turned into a vapor, so people will inhale it or smoke it. This is typically a substance that's not really soluble in water. And so that anytime, if you think about it, and I think one of the things to always remember when you look at how people use different substances, when you turn it to vapor and inhale it, it's literally in the brain right away. It goes right to the lungs, right to the blood supply, and it's right to your brain. Now, the cocaine salt dissolves in water, and that one is much more easily then solubilized and injected. And so it's the salt that people inject. I'd say much more often people will snort or vaporize the base of cocaine. And that's, I think, we just see that in the movies. You don't see it in real life, at least we don't. But so the effect of it, of course, is increased energy. In fact, I just had somebody who was using quite a bit of cocaine, and she would not really use it to get that amazing euphoria. When she would use cocaine, she would get this increased energy, and she would tell me how she would stay up for hours just kind of cleaning and bumping around her house. She'd feel really good. She wouldn't describe it really as euphoria. So everybody's a little bit different. But often people will get this intense pleasure, and a lot of patients will describe it as kind of a full body orgasm. And they often talk about how using cocaine and sex it's probably the best sex that you'd ever have. And so that's often what draws them to it.
And then when they drink alcohol on top of it, of course, it makes cocaethylene, which then prolongs the effects of both. And so it helps it last longer than that. Yeah.
And so I think a lot of times that's why it's kind of a bar drug, if you will. People will drink alcohol and then use cocaine, and the cocaine will last much longer. And again, cocaine is actually metabolized to benzalgonine, which is actually excreted in your urine. Now, the thing to understand really about this substance is that this is what we're testing for, and there's almost nothing that looks like it. So if you get a positive cocaine urine drug screen, it is rarely something else. We pretty much hang our hat on that dip if it's positive for cocaine. So what's the mechanism of action of cocaine? Well, basically it's blocking the catecholamines and serotonin transporters. And so what happens as a result of that is you get this increased extracellular dopamine. And so that dopamine is binding with a dopamine transporter. You get all this extra dopamine, you get this real great rush and euphoria. So it's all about dopamine.
All right, so then we'll talk about meth. I always get to talk about meth. It's like so weird to say I love meth. I just love talking about it. So it is still way more common than opioids. So we're going to spend a lot of time on this one. The other stimulants, yes, are there. Even cocaine, like Kurt mentioned, most people do not get addicted to cocaine. It's more of that weekend thing, like all the other ones he talked about, whereas methamphetamine's total different ballgame. So it is a psychostimulant drug, and so you can kind of see how it looks if you're really into the structure thing next to other stimulant drugs. So cocaine, MDMA, which is, of course, in that spectrum. This is ecstasy. And then like your amphetamines, like your Vyvances. This is your Ritalin, modafinil, which is used for people with narcolepsy. So you can kind of see they're all in that same category. So a lot of common names, and these are things, do we see a lot of them? No, speed, ice, crystal, I see those. I don't really see much of the other ones. Redneck cocaine is kind of where it started when people first kind of came up with that. And Candy, I'm going to answer your question now because yes, it really has kind of stayed pretty darn stable. Methamphetamine has. There was a little bit, actually, I'm going to get to that in a second. So I'm going to kind of pause the rest of the answer. So meth is man-made. It's very potent. And usually it kind of comes looking like this or crunched up versions of this powder, often mixed with who knows what else. So if we go back to 2017, you can see about 0.5% of people use meth, but it is involved in a lot of overdose deaths. So typically, it's not going to cause its own overdose death, but it's involved in them. Now, there are patients who can die of meth overdose, but it's much more likely because it's the cardiac complications or the other complications. This is, again, older data, but almost 1 million people had meth use disorder, but, high school students using meth, that's actually a pretty high number, especially then, and much more common in the Midwest and Western East Coast, much more cocaine. It is now primarily produced in Mexico. Prior to that, we'd always hear about the meth labs, and that's when, Sudafed went over the counter or had to go behind the counter. And so it ended up being safer and cheaper and more potent if you got it from the border, and whether that's good or bad. So if we're going to look at meth versus cocaine, meth clears more slowly, as you can see. So this is clearing of cocaine over time. So this is when you put them both, take them both, you can see how they both light up the striatum. So a lot of the dopamine receptors, cocaine's gone fairly quickly. Meth hangs on a little bit long, well, a lot bit longer. And so I like these visuals. So cocaine, as Kurt just mentioned, increases this dopamine in between the intracellular area because it blocks the ability of the cell to take dopamine back up. So the dopamine's coming out of that first nerve, and then it just kind of stays there because it can't get reabsorbed to go away. So this is more dopamine than you can see in a person who's got totally normal functioning, not on substances looking cells. Meth, the reason it's so much stronger is not only does it block that dopamine reuptake like cocaine, but it also tells this side to make more faster and push more out faster. So we have just this greater amount of dopamine in that intercellular area, excuse me. So anatomy, here we go, dopamine cell, dopamine transporters. So this is where the brain is pushing it out, the dopamine receptors where the dopamine binds, and then what is your brain? This is your brain on meth. Not to go back to that commercial where I've had patients tell me that this is your brain on drugs egg commercial actually made them hungry and then want to use more drugs versus the impact it was supposed to have. So your body, your brain, you know, we always kind of adapt to the situation that we are in over time. People who move to the South and then they come back to Minnesota, they're no longer used to the cold, even if they grew up here. Very similar in the brain. The brain will just kind of try to adapt to all this extra dopamine. So it actually lowers the amount of dopamine transporters. And this will help explain why they will never, ever get that same high as they did the very first time. So when they use meth that very first time, it is the highest amount of dopamine they're going to be able to get because the body is going to try to downregulate and adjust things to keep it as balanced as it can. Clearly not 100% successfully. I hope I did Nora proud. This is like my idol in the world, Dr. Volkow. And then it also shows that you break down metabolism slower of the dopamine. So you can just kind of see more brain changes the longer you use methamphetamines. All right, so here's my patient. Again, we're going to kind of jump back to her throughout. So 20-year-old female. This is as of then. She is now 21. She turned 21 this last winter. At age 13, she started using alcohol. She says she doesn't drink now. She hasn't drank in over a year. She just doesn't like it. We do see this. Age 14, started using marijuana, very intermittent use. At that time in her mid-teens, she did go to treatment several times for marijuana use and now hasn't used it in I don't know, used it very intermittently, like once a week. Does not vape it. Age 16, started using meth. Because, you know, the person she was using marijuana with said, hey, try this. And she went to treatment many times between 16 and 20. That's how many times she can tell me. At age 20, so shortly after all this, that is when she was actually introduced to fentanyl and heroin. So her primary drug of choice was meth use disorder up until the last 6, 8, 10 months. Now she's kind of developed this opioid use disorder on top of it. She moved from Southwest Minnesota to North Central Minnesota when she was 13. So coinciding very well with when her use all began. An older brother, an older sister, and a younger sister. She said her dad died when she was 18. This has been a huge issue for her because it was a very rapid declining dementia and she just really hasn't dealt with it. This was, you know, the peak of her meth days. She says her mom is involved, but, you know, doesn't really want to dive into that. Medical mental health history, diagnosed with anxiety and depression around the age of 13, right around the time she started drinking. Doesn't remember the timeline. Had tried on many medications. I mean, she's one of those patients, if you name a med, she's probably been on it at some point. Never had been on anything longer than 6 months. She'd always been using something, whether it was alcohol or marijuana or meth or fentanyl, while she was given these medications. So she was never super compliant, in her words. She did have some cutting behaviors between 14 and 17, which helped with her anxiety, has not cut in several years. Diagnosed with ADHD around 16, coincidentally around the exact same time she started using meth. And she was diagnosed with PTSD in a combination of mental health treatment and jail, which we will get to. Diagnosed with schizophrenia, also at the same time between treatment and jail, just last year. She did have one accidental overdose around age 19. She had gotten a bunch of K2, so bath salts, all on that spectrum of stimulants with a bunch of prescription medication that she had been on. She said, I don't think I was a suicide attempt. That was her verbiage. Family history, she said, I don't know, maybe they drank too much. That's what all she's got. She doesn't really talk to her older siblings. They're married and have their own lives and don't approve of her. And her younger sister is kind of not in a great place, but not, you know, following the exact same path. She had a long-term boyfriend up until recently. He's very toxic. A definition of trigger right here, she says if she even smells the cologne, from somewhere else that he wore, she instantly gets sick to her stomach and starts vomiting. We'll go through some of the interim history in a minute. So now when I am meeting her, this was a couple months ago, she's now 21 years old, presenting in clinic for the first time. She says she's been sober about 7 months. She's got extreme cravings for opioids and meth. She's got a lot of using dreams, primarily opioids, but also meth. She's very edgy. She's very anxious. She can't sleep. She lays around all day, but can't sleep. And this girl cannot sit still. She denied having any sexual abuse or assault. Great question. But that's about as much as she'll go in. Nothing from the recent toxic boyfriend, nothing that she could remember predating her drug. She didn't say anything was unconsensual. Okay, so that's kind of where she's at now. Here's the medication list I get when I see her the first time a couple of months ago. So Zyprexa, and then Cogentin, which is supposed to help minimize the side effects of the Zyprexa. Gabapentin for anxiety, hydroxyzine for anxiety, lamotrigine, so Lamictal for, she says, I think they started it for schizophrenia. She didn't really know. Pramipexole for her restless legs, and propranolol. I don't know why I'm on that, was the answer I got from her. Okay, so just that's her right now. So what are the concerns with methamphetamines? Do you want to do any of this?
Sure.
Okay.
So we're going to leave that case so you can simmer on. It can just simmer for a little bit, and she will get back to it after this. The concerns about methamphetamine, obviously, this is a neurotoxic and damaging drug. I think it's so much different than some of the other things that we see. You know, some of the euphoria, it really wears off before the drug is completely out of the CNS, but it does accumulate in the CNS. And I think that's something to understand. Even at low dose use, we get a lot of damage to these serotonergic pathways, especially in the frontal cortex and hippocampus. And of course, at high dose, this is much worse, the striatum and the parietal cortex. And remember, this is why we see patients who've been using methamphetamine for a long time that have had issues with their moods, right? They frequently have caused damage to these areas that really affect our mood. And so we'll see them in the chronic depression and all these things. And this is really why it does cause that over time. Whoops. And remember, the intoxication of it is also dangerous because there's a lot of impulsiveness and risky behaviors, especially sexual risky behaviors associated with men having sex with men. Typically, when they're not gay, they will, and they've not had sex with men before, there's a high risk of that when people are using methamphetamine. And of course, because of that, HIV and hepatitis C are very common, often in long-term methamphetamine users. One of the problems, of course, is it can be manufactured in very small places. Although the majority of it comes from Mexico, there are still people mixing it up out in the countryside. And one of the biggest problems with methamphetamine is we don't have, you know, a Suboxone or a buprenorphine like we have for opioid use disorder. There's really no medication that just replaces it, that's a partial agonist or helps. But we do have some off-label things and that we do use. And of course, it's very highly addictive and it's very difficult to treat. And I think when we look at some of the acute effects, when we see people and they're acutely intoxicated, they can often be very aggressive or psychotic. And sometimes they'll develop psychosis over a period of time. But they typically don't eat. And I would say a lot of the patients I have there that are methamphetamine alone or meth with heroin or fentanyl, they are frequently very skinny. They will often gain quite a bit of weight, 60 or 70 pounds after discontinuing the methamphetamine use, which is also a problem for them, especially in women. They like that they were thin with the medication or with the substance. They don't like it when they're getting heavy. I think one of the things we always think about is suicidality, and especially when we see men having sex with men who have not typically had sex with men. There's often a suicide risk when that occurs, when patients wake up and realize what's gone on. Again, one of the big things with both cocaine type things and meth, there's really that hypertension and cardiac issues and seizures, especially when mixed with other things.
So if we're talking about this patient of mine, this is kind of from her history and what she had told me initially, things that she really could remember and had experience with. I put the suicidality in here because it was kind of all associated. And so it's definitely something to kind of keep in the back of our minds. She had never been hospitalized that she could remember that I could find with any of these other things. So that's just what we have to think about.
That's interesting. And again, remember the impairment long-term, and she will talk about the schizophrenia in 1 second. The impairment, some memory issues, of course, processing speeds, obviously some motor skill issues when using, but chronically, it's really this pleasure issue. I mean, do you have slides in there? Do we have slides in this one about what meth does to the dopamine levels compared to other things? So the interesting thing about methamphetamine is if you look at it compared to even cocaine or your best meal ever, let's start with your best meal ever. You
mean like your jalapeno popper pizza?
I just had a jalapeno popper pizza from this amazing place in St. Cloud, and my dopamine levels probably went up 200%, maybe 300. It was that good. But if you use cocaine, you may see that your dopamine levels may go up 600% or 700% of normal. The problem is if you use methamphetamine, there are some studies that suggest that may even go up 2,000%. And that's the difference, okay? So again, imagine when you've been like that and you're working and you can work night and day and you're a construction worker, what happens when you don't use? You can't get going. You feel depressed. And so it can be really an issue, especially in I'm thinking one patient I've just seen who's a construction worker without methamphetamine, working those 12 to 16-hour shifts is difficult. So again, chronically, methamphetamine causes problems.
All right. So in this patient, a lot of memory issues, she's kind of vague or, almost what you'd consider like a poor historian, but she's just like, I don't know. Now, could that be her age where she didn't really have an executive functioning anyway? It's multifactorial. Like I said, she was very fidgety, but, the talking was a little bit like this. Nothing made her feel pleasure. And that's the other thing. Not only do they not have the energy to be able to do the work and to look manic in a way, that's the whole bipolar diagnosis they try to get. There's nothing in their world that's ever going to get them to that level of pleasure again. And so long-term, some psychosis will get to that, violent behaviors, depression, we'll kind of get to that more with her as well.
So how about withdrawal and abstinence syndrome? Now, when people do withdrawal from methamphetamine as well, I think often we just think that with opioids that people get sick, but very obviously when people stop using methamphetamine, a day or two later and lasting for even 8 or 10 or 12 days, they can crash, and they'll tell you about how they crash. They'll sleep all the time. They'll have a lot of drug craving. They'll eat a lot because they haven't been eating. But often this is what gets them back using again, is this dysphoria and this irritability. And I think the thing that I've always noticed when people have been using both is how irritable they can be. And again, the post-withdrawal stuff can last months, where they'll have sleep disturbance, they'll have appetite changes, and they'll just be down. They are dragging. And there's not enough caffeine in the world to kind of pull them out of this. So it's really pretty interesting.
Yep. So here's my patient, like the big things. And, this is where I'm meeting her, sort of. So we'll get to that again. Okay. So this is where the case really was amazing to meet this lady a couple months ago. So in the summer of 2021, so last summer, she was actually arrested and she thinks it was on a warrant, but she doesn't even remember. Within 24 hours of being in the jail, she started to have visual and auditory hallucinations, yelling and screaming, banging on the cell door and on the cell wall, and paranoia. Why do I know this? Because I actually saw her in the jail. Didn't make the connection until our conversation, but I actually saw her as a patient in the jail. She was on suicide precaution. She initially wasn't a threat to herself or others. You could not open the cell door. You could not go near her. She was the most, and I remember calling Kurt saying, "Oh my God, I have now seen meth psychosis." And he said, "No, I've seen meth psychosis too." And then,
I have.
And you have. But this was like unlike anything I've seen before. And I have been in psych hospitals, and this was crazy. So I gave her the diagnosis like after she had been booked as meth-induced psychosis. I said, we just need to keep her safe, and we just need to watch her. And at this point, she wasn't taking any medications prior to being booked. So, you know, with all of this, there is a transient psychotic symptoms of patients who are using methamphetamines. Up to 40% of people who use meth. So this is actually a lot higher than I ever would have thought it would have been. Auditory hallucinations, all the types, very paranoid, persecutory delusions, ideas of reference. So they have kind of a lot of these negative effects that you would associate with schizophrenia. So how common is it? 44% of meth patients, which we just mentioned, people who use it recreationally are more likely to develop symptoms versus the general population. So general population versus people who are using meth, quite a bit higher to get any type of psychotic symptoms. 11 times more higher.
If they're
regularly using it, recreational people using it once in a while, which very infrequently does that happen, unless they're coming off of an opioid. Typically, people are using it regularly. Meth is their drug of choice daily, 11 times more likely than the general population. Average time between their first time using methamphetamines and their psychotic symptoms, this is not that much time. My patient, remember, had just smoked it. She had never injected it. So 1.7 years, she was around 3 years when she had this psychotic thing, but this is not much time. So it's definitely something to be aware of, and something that I would have never even thought was this common. So there can be variability, though, in the duration of the psychotic symptoms. It can last days to months. Now, if you're a type A person, which is not related to your personality type, but your genetic type of, or your use history. So if you have symptoms that lasted less than 1 month, typically with less than 5 years of use, I'm sorry, I'm going to back up.
Please.
If you've used methamphetamines for fewer than 5 years, the chances are you're only going to have psychotic symptoms less than a month. You're not going to go beyond that. People who had used beyond 5 years, they can have up to over a month and who knows how long symptoms. 30% can have symptoms up to 6 months. And that is just because of the big changes in all that neurocircuitry. There is a dose-dependent relationship, and this is where it's extra scary. So the people who are using all the time, but then maybe on the weekend they'll use more, or if they have to go work for extra days, they'll use more. That binge use is definitely associated with higher psychosis. If you decide to be abstinent from methamphetamines for a period of time, and then you go back to methamphetamines, the chances of psychosis coming back is actually almost inevitable. So people who have had meth psychosis really need to maintain abstinence in whatever way we can help them with. Likely genetic, 5 times more likely to develop schizophrenia in the family member. So if you have a person in your family who has meth psychosis, it is associated with schizophrenia. So other people can be at risk of schizophrenia, and you can kind of see that here, a lot of genetic overlap. This study in Thailand was really kind of neat because they had a lot of people, over 1,000 people, even just one episode, and almost half of them had been diagnosed with schizophrenia within 6 years. So, you know, Candy made that comment in there. Is this really schizophrenia, or is this really drug induced? And then how do you differentiate? So people who have an underlying psychotic disorder actually can, you know, this can exacerbate it. So kind of like, you know, schizophrenia with marijuana. People who use cannabis a lot can actually bring out their schizophrenia diagnosis that they maybe wouldn't have ever developed, but because they had the predisposition, now they're developing it. These are risk factors that I think if we all thought about it, would make sense. But remember, it is higher in smoking versus injecting. Now, if we're comparing meth psychosis versus schizophrenia, and this is never a black and white because nothing in medicine is black and white. So people with meth will typically have higher visual and tactile hallucinations. So they're feeling things, they're seeing things, but they're not actually hearing things as much. They don't have as much of the withdrawal blunted effect. They're not as disorganized. And they typically have more movement disorders. So they'll kind of have more of those almost side effect looking disorders from antipsychotic medications.
May I throw a twist into this?
No. Yeah.
So I actually saw a patient a few years back who was in actually with a child and asked his child to go to the waiting room after the visit, and then had said, geez, I got this question to ask you, and I'm not exactly sure how to say this, but I've been hearing voices. Okay, and he's a big burly guy, probably 250 pounds of muscle, and he's a construction worker. And so he'd been hearing these voices, and they've been pretty steady for the last week. And he could ignore it, but they were there. Now, again, she just said that methamphetamine typically is more visual and tactile, but in a construction worker, that would be one of your first thoughts. And I asked him whether he was using anything like methamphetamine, and he said absolutely not. He'd never used meth in his life. And so the next thing to ask is, have you been smoking marijuana? Because marijuana as well can increase your risk of schizophrenia and psychosis. And in fact, he had been for 20 years. And so in fact, he ended up having a psychosis that was getting hallucinations that were auditory from that. And when he stopped it went away. But those are the two things that you kind of think about when you see somebody is it one or the other, especially with the high THC levels.
All right. So what are your treatments if a person is having this psychotic kind of episode? Acutely, it is the benzos. You need to calm down their agitation. It helps them kind of get over that insomnia. A lot of them haven't slept in a really long time because of the meth, or they haven't had really, good sleep. And then when they stop it, they kind of have this crash, yet they still can't sleep because remember, it has accumulated in their CNS. So it kind of takes a lot longer to stop impacting the other areas of the brain, even though they don't look under the influence or high at the moment. You really want to watch physical restraints. This is a very old-fashioned way of handling things, is to tie people down. Much more issues with rhabdo, lactic acidosis, hypothermia, and all of those. And you really want to minimize any kind of stimulus. So within her first 3 days in jail, my patient again is starting her withdrawal. And by day 2 is when I saw her kind of at the beginning of her psychosis. On day 3, I did give her some Ativan on day 3 for 3 days, not the first 3 days. I did write a PRN Ativan order, which isn't always loved in corrections, but it was there. She refused it mostly. I think she only got 1 dose because of the paranoia. She thought we were poisoning her. She was seeing things on the walls. It was extreme again. She was in a cell away from all other inmates. So she was kept in a private cell where you could make it a little bit darker. Like the worst thing that we could have done would have been put her in a normal cell block with a lot of other noise and a lot of other behaviors. By the end of the 3rd week, now she is still having psychosis. She is still very psychotic, almost as crazy as she was the first week in extremes. I did have to give her a dose of Haldol. That was kind of what I had on hand as she started to try to bang her head against the wall. Oops. Oh, that happened. Against my advisement, because they were trying to get her committed because of her extreme behaviors and this psychosis. I said, no, you cannot send her to court. You cannot deem her incompetent. You cannot do any of this until we are at least a month out, because this is still the meth. And they still sent her to court. She was deemed incompetent, and then she got put on a mental health hold. The beginning of the 4th week, another provider started her on olanzapine, so Zyprexa, and then benzocaine, so Cogentin, and had given her the diagnosis of schizophrenia. I had just continued to write meth-induced psychosis, but somehow she gets this diagnosis of schizophrenia. They also started her on Prazosin because they felt that all these visual hallucinations were PTSD. She got out of jail at the end of that 4th week, but went right to a mental health hospital. They continued those 3 medications, and then they added all of the other ones within 1 week. So she is just leaving that 4 weeks, that 1 month of getting off of her meth. So what should happen in this situation? You know, do you give the neuroleptics? Do you give the antipsychotics? Now, Haldol wasn't the right choice. I did not know that at the time, and I didn't have much accessible. So I did give her the 1 dose. There is an interaction between meth and Haldol, which can actually create more issues with GABA cells, which can then create more longer-term issues, increasing seizures and other movement disorders. Again, I give her 1 dose. Can increase QT prolongation if you give any antipsychotic. Now, most patients will lose the psychosis, or the psychosis will start to wear off within that first week without any meds. Now, we are going with her, was almost on the month, still hadn't worn off. If you give a bunch of antipsychotics, you can actually increase their depression, the anhedonia, even long-term, and it actually can increase then their vulnerability to relapse, because again, they're in that depression and they just need something to get out of this funk, if you will. You should try some psychosocial interventions. It's more of a keep the patient safe. So this is kind of where she's at, which is why the Cogentin was started, and I'll explain that in a second. So now, when I met her a couple months ago, I am still seeing her, by the way. 8 months later, she is still on that whole long list of meds. When I met her, as I said, these are the same things I had put on the other slide. So she's still having all of these symptoms. I didn't put on here the anhedonia. She's just like, blah, that's her lays around all day. I did start her on Suboxone. She had not actually started her fentanyl and her opioid use until after she had gotten out of the mental health hospital. She got out of the mental health hospital, started using meth again, and then realized that just made her more anxious. So then started to use the press pills, so the fentanyl, and now she craves them both. The using dreams went away, her cravings went away when we started her on the Suboxone. She did still have, and still does, has very, very infrequent auditory hallucinations. They are not persecutory. They're not, she can ignore them. They're just annoying now. So I actually am having her see one of our partners who's also a psychiatrist. He's transitioning this is, what is it, Latuda, yeah, off of Zyprexa. Olanzapine Zyprexa is actually like the least impactful one in any type of psychosis or psychotic break, especially with meth. The benchtropine, so the Cogentin, will not help her restless legs, will not help the movement disorders caused by her psychosis. So it looks like she's having a side effect of the antipsychotic, but really it's just part of the psychosis. And with this transition, her hallucinations are improving. And so we've had a lot of conversations about this. What does this look long-term? He still thinks she's got meth-induced psychosis, does not think she has schizophrenia. He said it can take a year or more for this to all continue to go away. So we are just watching it. She is deathly afraid, though, of taking away her meds because she doesn't want to go back there. So chronically, most patients inevitably are going to get started on an antipsychotic medication. After the month, after the 2 months, should you start them? Most likely they will get started, and it's not the wrong choice because they are having hallucinations and, you know, they're paranoid. So after a month or 2 off of their meth, it's a safer option to start them than within that first month, but it should be discontinued. I know you've talked about your patient with cannabis that got psychosis and got started on antipsychotics and had to get stopped. But, you know, like I said, this can persist a long time. And so it's important to really support the families, support the patient. So do you want to go through some of these studies?
Yeah, and just quickly, and I don't think there's too many slides left. I'd have to look, but just so that people understand the past year methamphetamine use, when we look at some of the national studies that have been done, especially, you know, 12 years of age and older. I mean, really, if you look at that 18 to 25 year age group, that's still where we're seeing the majority of the meth. Some as we get people older, relatively infrequently in the young kids. And if you look at kind of these use behaviors, if you look at kind of methamphetamine use behaviors and other substance use behaviors, you can kind of see, see a little bit of difference, especially with the substance use and mental illness. You see what percentage of people will be using those particular things. And still cannabis, remember, cannabis is still the #1 illicitly used substance. And so we always kind of think about that. I think that's, we can talk about all these other things, but marijuana still causes us a little bit of stress. Lifetime prevalence, of course, and mean number of other substances used. And we're looking at that age group that's 18 and older. And if you look at, you can really see as time goes on, the types of drugs that people are using there as they go across up to almost 80% when we're looking at PCP. But it does. The mean number of other substances ever used goes up. If you've used PCP, you've probably used lots of other things. When if you look at things like cigarettes, that doesn't necessarily mean you've used a lot of other substances. You probably tried marijuana, maybe tried some other things. But there are certain drugs that when we see people use them, we know that at that point they probably had 4 or 5 other substances they've used. And especially if you look at methamphetamine and heroin, that one's really right up there. And when you look at, I can't read that. It's, I can't read.
Okay, so percentages of patients who go into heroin treatment programs. So this is, really before the fentanyl thing. So if a patient's primary diagnosis is a heroin admission, you can see that in 2008, 1 in 50 of them also were using meth. And in 2017, 1 in 12 were also using methamphetamines. So this is obviously a rising thing. Like Candy had asked at the very beginning, methamphetamine has continued to go up regardless of the opioid epidemic. It has continued to do the same time for reading. He has like 400 pairs of glasses.
Candy, what was going on is one of our things was covering up some of the stuff, so I couldn't read it.
Anyway. So if you really ask, why do people use opioids with methamphetamines together and what do they feel? And you can see, do they like the high, the roller coaster effect? So that's your bipolar looking effect. And you can just kind of see the differences in here. And a majority of it is just what they feel, what's available, the balance. So when they're coming off opioids, they use the meth and vice versa.
And I think that's the one thing we always have to think about when we see bipolar disorder on people's charts. And I just had it this morning in a patient who was using methamphetamine and fentanyl. And if you're concerned that somebody might have bipolar disorder, you need to be asking the questions about substance use, because more often than not, it's that.
Yeah, I actually had a patient yesterday. He's 37, and he said, they told me I have bipolar, but I don't. I've just always used meth and fentanyl. Like, that's what it is. Yeah. Like, he has enough insight to understand his diagnosis better than, most. But there's studies out there where there were these meth study hotspots, and you can kind of see the start areas where these hotspots were studied. And they kind of just did a bunch of surveys to see why people felt meth is safer, because it is harder to overdose and die on. It's really cheap, and here's all your other things. And a lot of it has to, of course, come down to it's there, and why not use them together? As far as sending a patient to treatment who has a primary opioid use disorder, and you send them to treatment with their buprenorphine with Suboxone, or you're treating them in your clinic, patients who also co-use methamphetamines need a lot more close monitoring. You need to see them more frequently, because they are much more likely to relapse with both. And overdose deaths that have meth on board, you can just see, of course, the colors have gone up a lot everywhere. Who uses it the most? I mean, all things have gone up. Alaska Natives, American Indians have really gone up the highest. And if you look at where they are, kind of mentioned this already, cocaine tends to be more in the inner city, whereas methamphetamines and other types of amphetamines are going to be much more rural. Not, of course, the black and white there either. This is talking about prevention and risk factors, kind of the things we're aware of. NIDA did this whole study, this PROSPER, which really focuses on interventions, a different version of an intervention than DARE. I'm going to kind of flip through these. This is what it showed when they did these interventions. And then this is social interaction. So this is one way that, methamphetamine can be treated. It's increasing other pleasurable things to kind of replace the pleasure of meth. So you need to have that socialization there. You need to have positive support growing up. You need to have that positive enforcement in your life to then help mitigate relapse or mitigate use of methamphetamines to begin with.
To be clear, that was a study done on rats, I believe. Wasn't that the one where the rats actually chose to be with other rats instead of using methamphetamine? So it seems to work in rats, that they like to be with other rats.
They don't have a frontal lobe. Just kidding.
Yeah.
This just shows that, can the brain get better? Yes, you can see it does improve, but it can take a long time. It's kind of like when patients ask about how long do I need to be on, my Suboxone, that it could be lifelong. Methamphetamine, are they ever going to perfectly feel that euphoria from the rest of their stuff in life ever again? It's never going to be like meth. Hopefully, the dopamine receptors and all of that do kind of regenerate and make life more enjoyable for them. There are, again, no treatments, FDA approved medications. Contingency management is by far the most effective. This is, of course, one of the hardest things to get covered, to pay for. It's basically giving patients positive reinforcement for abstinence from methamphetamines.
I think the thing to remember too is that there are off-label drugs that we use to help with the cravings. Everybody always asks, well, why can't we use things like Adderall or Vyvanse as kind of a substitute for methamphetamine? And those studies were actually done in Australia. And although initially they thought that it may have had some benefit, that was later debunked. We use things more like topiramate, gabapentin, and sometimes you've seen some of the studies maybe on Wellbutrin, which also can be misused. But those things sometimes will help with the cravings. And I'd have to say that probably my favorite still topiramate. I think Heather uses some different things, but there are some off-label things.
My approach is, yes, I use lamotrigine, like my patient came to me on. So clearly we're not getting rid of that one. No, my approach to treating a patient with methamphetamine use disorder is really figuring out what happened to them. Let's go way back, childhood trauma. Let's address those issues. Let's treat their coping. Let's help support that, the CBT and the EMDR type things, and then work forward. Here's some of those studies, the combination of bupropion with naltrexone. They have positive results. It's not anything earth-shattering. But this is where you're supposed to find hope, reading every one of these things on this page. Just kidding, don't. This is what the National Institute on Drug Abuse, NIDA, National Institute of Health are studying. So there are things on the horizon. Some of them are other medications, as you can see over here. And then some of them are total new in study future medications.
Even transcranial magnetic stimulation has been looked at. So again, I don't think there's been any huge earth-shattering results from that, but that's also being looked at.
This picture reminds me of something out of like Netter, one of your early med school books from like when you were in med school, because this is just like such a humongous contraption.
Oh, we didn't even have drawings back then.
Chalk.
All right.
So this is antibody treatment for meth. So it's trying to give your body, giving a patient antibodies, which will then capture the meth before it can get to the brain. So that's what these things are. So that is also being studied. So in summary, meth is clearly a potent drug, highly addictive, a lot of potential complications, even more scary ones than I would have ever thought ahead of time. Treatment is difficult. A lot of things that are being studied. I love the NIDA site, which is why I left it on there, is because you can just kind of see in real time almost what they are doing to try to help. You can see that the baclofens and the Remerons and the Adderalls are just not effective treatments. And so kind of goes through some of those. So anyway.
Any questions, if you want to close that? We're happy to entertain any questions before we go. We just got a couple of minutes. if you're seeing anybody with opioid use disorder, you're also seeing patients with methamphetamine use disorder. So it really is, nowadays we see more of that than I think we did 5 years ago. 5 years ago, it seemed like more people were one or the other. And I think now almost every patient has kind of touched on both. So, all right. There being no questions, we will hang around for a moment in case people have anything they want to chat about. Otherwise, everybody have a good week. And tomorrow, again, we have the talk East African culture stuff from Yusuf. So it should be a great talk for those of us that take care of that patient group.